programs. Each will speak about an hour. We have Dr. Bertolotti, who received his degree, DDS, from the University of California after he had worked as getting a PhD in metallurgy and as a ceramic engineer. He is currently a clinical professor of biomaterials at the UC California, and he speaks extensively both nationally and internationally, and he's also published nationally and internationally in various research and teaching publications. He has been ranked as one of the top 3 speakers in dentistry today on programs all across the United States. So with great pleasure, we bring Dr. Bertolotti.
Okay, there we go. Yeah. Yeah, well, thank you. It's a pleasure to be here. Make sure the guys have me on the tape they want there. The other thing is that we ought to just douse the lights down a little bit, because obviously it's going to be hard to see slides if we have full-blown lights. And for the purpose of video, I'm sure that's another factor. Mary will help us there. She's pretty good at adjusting lights. She does it internationally. That's her specialty. Yeah, thanks, Mary. They're right on the screen, of course, as predicted. You know, it's amazing how hotels always put the lights right on the screen. That's why we bring a BB gun along to shoot them out when I get very frustrated about this point. That's good, Mary. Thank you. Mary's specialty is turning out hotel lights, you know. All right. She's bringing a lot of other things, too. Thank you, Mary. All right. Now, my role here today, I'm certainly not any kind of specialist in biological dentistry. I'm a specialist in restorative dentistry. And what I see my role here is you guys are mostly into alternative filling materials, things like that, and I have no problem with that. The reason I have no problem is that I don't need amalgam. Okay, I don't need it like I needed it 10 years ago or even 5 years ago. And the problem I see with all this is if you're going to go to an alternative material such as composite, posterior composite, you know, for whatever reason you intend to do that, that's fine. But where I find the big problem is if you don't know how to put in the composite properly, then the tooth dies and then you do endo, and you guys don't do endo, so then you got nothing. So you're in deep kimchi, right? Now you can turn the note lights on if you want. There, it's fine. So, you know, I want to show you how to put in a proper composite because that's very critical. Now, I speak on a lot of other adhesion topics and many, many things, and Ed's given me 1 hour today, which isn't very much. I'm used to taking 2 days, so. Let me go through the posterior composite technique because I think that's going to be very critical for the success of your dental practice if you're using these alternative materials. Then if you want my comments on some others, well, I'll be real happy to try to help there. First of all, we need to look at posterior composite technique because there's a lot of amalgams that you're going to be replacing or maybe placing for the first time. And you want to do that properly because I think you get in big trouble if you can justify taking an amalgam out. I have no problem with that. But if you put in a clinically deficient composite, I think you get you in an awful lot of hot water. Now, if the composite's in good shape and clinically serving the patient properly, I don't think you can get in trouble at all. Problems happen when when you start doing deficient dentistry as a result of something that, you know, someone's going to question the rationale for doing it in the first place, and then you do a sloppy job. Then you're in trouble. I see a big problem there. So. One of the problems with composite is that it traditionally, when you place it, it shrinks about 4% by volume, which means that basically it shrinks away from the cavity prep. That leaves you wide open margins, recurrent caries, stain, and all kinds of problems, even broken teeth if it isn't bonded properly. So what we need to do then is take the shrinkage of composites, it's around 4% by volume, and reverse it such that we don't effectively have a shrinkage away from the cavity prep. And that's one thing we need to do. Secondly, if we're going to place composites in the posterior region, a lot of dentists have problems getting adequate contacts, proper anatomical form, proper tightness. That's a big problem, so we need a matrix system that can do that. Now, first of all, let's take just a moment here to reflect on some of the materials. The American Dental Association, which I'm losing respect for rather quickly lately, gave the seal of approval to a material called Full Fill the early 1980s. And the reason was that full fill met the specification in regard that it had low wear rate, below 150 microns at 3 years, and I believe 2 studies. See, it came in at about 140, which squeaks in a little bit under 150. Well, okay, that's fine. But when you put it in the teeth, as you observe probably clinically on certain surfaces like occlusal linguals, things like that, on molars in particular, you find very high wear rate. On MO on the same molar wasn't so bad. So clinically it really didn't work very well, even though it had the ADA seal of acceptance. And about the same time the ADA gave the seal of acceptance to full fill, the researchers out there were telling you that a microfill would never work as a posterior composite material because microfill is at a little small particle size and they just wouldn't be acceptable. And what you were going to need is a hybrid, that is a great big rocks of stuff with fines in between and then microfill in there. A lot of famous researchers told you that. Well, that it turns out to not be quite correct because here's heliomolar, which is a microfill, light-cured microfill. And look at this, the wear rate is a little bit under 40 microns a year. Now this data you're looking at on the screen, and I didn't make this up, this is intraoral wear data from Jack Mitchum at Oregon Health Sciences University. And there's another study that came out of Alabama, Carl Leinfelder's group, that has data that's very, very similar, correlates perfectly with this. You know, the number's a little bit different, but the correlation of the materials is exactly the same. And then you get into the laboratory with a material called Concept, which is microfilled heliomolar that's been cured in the laboratory under heat and pressure, so the conversion of monomer to polymer is a lot better. And the wear rate drops from about 40, just under 40, to just a little bit under 30, which is a substantial gain. But on the other hand, you trade off some properties there. What you trade off is a little bit better wear character for a lot more brittleness and a lot more chipping. So clinically what you see is more chipping of margins and chipping of marginal ridges and all that kind of stuff. So, you know, it's a serious problem we have. Now, in terms of clinical judgment and using heliomolar or Concept, I feel that most of the time you can use heliomolar quite effectively because you can conserve occlusal enamel. And when you get into an inlay-onlay situation with Concept, you have to cut away a lot of enamel to get a divergent prep. So, you know, what's better? Some undermined enamel properly bonded with composite, such as heliomolar, or Concept on the occlusal. Which are you going to choose? Well, I'd choose the undermined enamel anytime. Because Fusiyama has shown in his textbook you can back enamel with composite and get very, very good clinical service. Now, this, the worst possible dentistry you could do is GV black dentistry with composite materials. That's an absolute clinical fiasco. You're doing that stuff, you better reevaluate right away what you're doing, because that is an absolute disaster. Okay, we're supposed to be a bunch of dental doctors, not dental destroyers, and the worst thing you can do is do a GV black prep and then put in a composite. Particularly if you use a baser liner, that's even worse. So if you're doing any of that, you really got to reevaluate what you're doing. Now, and to be fair to the materials that are out there, there's not just one single product that's any good, like heliomolar. There are, in fact, 3 that I could highly recommend based on good, hard clinical data. And the 3 that are on the screen there are the ones that would be first choices. Heliomolar has probably the best long-term data, going back more than 7 or 8 years now even. But the material called Herculite, particularly in the incisal shades, has very comparable properties to heliomolar in terms of wear. So that's another possibility. And then recently in the Journal of Operative Dentistry, Stanley Wendt, who's from the Leinfelder group, he published a paper that showed that clear-fill photo posterior had the single best wear rate they'd ever seen in the history of studies at Alabama. It's the single best material they've ever looked at. Clear-fill photo posterior. Now, clinically, these aren't enough different that I think you'd see any major changes there. My favorite is heliomolar because it stays polished and looks real pretty, and I've used it for more than 5 years, and I've been very, very happy with it. You know, of all the composites we put in the last 8 years, I don't think we've had any failures at all. But you got to realize I don't use any basin liners either. I etch the dentin 100% of the time. Now, that might be a major factor there. Okay, but we have no do-overs in 8 years, and you can come in my office anytime you want to and look at some 5, 6, 7, 8-year-old composites, and you don't think they're put in the last year. I mean, these margins generally don't tick. You see just the slightest little bit of wear. I mean, they're really phenomenal. They're all done with heliomolar. So, you know, when I have that kind of success, why do I want to mess around with using Herculite or photo posterior? I mean, I'm just not going to take any chances. Now, this is a photoelastic experiment here designed to show what's wrong with doing light-cured posterior composites. if you go into Fusuyama's textbook, this is in chapter 1. And by the way, if you haven't looked at Fusuyama's textbook, I noticed they had it on the table out there. It's a very fine book. Now, what Fusuyama showed was that that light-cured posterior composites are inherently a bad idea. He told me that 10 years ago, and it didn't really sink in until I saw this photo a couple of years ago. But what he's done is he's put in increments of light-cured composite here, turned on the light, and then these photoelastic rings, they indicate the stress lines, which is an indication of flow of the material towards the light. For example, here on the cavity prep on the wall, it's trying to pull away from that zone right there. It's trying to shrink away from that zone. And the other problem that you have with photo posterior composites is that you include bubbles and defects like this right here. And if that occurred on a margin or any area like that, of course, it's an obvious source of recurrent caries. If that occurred on a dentin area, you'd have a source of sensitivity, clinical sensitivity. So while the idea of incremental fill is a good idea, I mean, inherently a good idea that you're reducing stresses, reducing volume shrinkage, the clinical problem is it doesn't work. And some of you found that by clinical experience. You've been putting in APH or TPH or mystery pH or something like that, getting recurrent caries, sensitivity, and all kinds of problems. About half the blame belongs on the fact that it was a light-cured composite. And the other half the blame is probably because he didn't etch the dentin. Okay, so we got to take a look at that. Now there's an auto-cured composite by comparison. You'll notice in the auto-cured composite there's very little stress, first of all. There's very low stress levels. And secondly, you'll notice that there's some bubbles in here, little bubbles. Now, I always thought that bubbles would be a bad idea because, you know, you stir a paste and paste together and you generate a bunch of bubbles, and that bubble is the source of what I thought to be discoloration and high wear and a bunch of other things. So I asked Fusuyama about that recently. I asked him, I said, you know, I just feel a little bit uncomfortable with those bubbles in there, even though there's not very many of them. He says, oh, bubbles are a great idea. Should have a lot of bubbles. I thought, oh boy, here we go again, you know. Now, Professor, why are bubbles good? I don't understand. He says it's very simple. They bounce light around so that an auto-cured composite then bounces light and it becomes chameleon, and you don't need a lot of different shades. 1 or 2 shades is all you need. Oh, that's a very interesting point. I never thought about it. Now, the other thing that it occurred to me at the time, I said, well, you know, I just thought of something. Those bubbles in there, they don't shrink from polymerization, do they? Well, they don't. So how about if we had 50 volume % bubbles? What would the consequences of that be?
Swiss cheese.
Well, Swiss cheese, yeah, but enclosed bubbles now. No shrinkage, yeah, 50% shrinkage, huh? Now, isn't that an interesting concept? So what we did is we made a composite with 50 volume % bubbles by basically shaking in an amalgam shaker, you know, triturator. Sure enough, the shrinkage is about 50%. So you may see a liner, composite liner in the future that's in fact 50% bubbles. I'd predict that you're going to see that, unless somebody can figure out how to reduce shrinkage some other way. So that's kind of interesting concept. Now, there's my opinion of DiCal summarized in one slide. If you're using that stuff, I recommend that you go through your office, take all the DiCal and throw it straight in the trash can. That's the worst clinical error you could make in restorative dentistry, use DiCal. The single biggest error you could make in restorative dentistry. Because if your professional opinion, you think that pH 12 cottage cheese is an adequate base, you guys aren't using amalgam, but suppose you would be, all right, under amalgam or under a brittle material called composite, then you should continue to use DiCal. Because it becomes either cottage cheese in 6 to 12 months or it disappears, one of the two. There's a nice paper in the ADA about a year ago that talked about disappearing DiCal. Now, if you think a space under a composite filling is a good idea, then I'd continue to use DiCal. Now, here's the myth. You've been told in dental school that DiCal is necessary, or at least calcium hydroxide is necessary for dental bridging. That's just pure bullshit. That's not right. And that's why I gave you that abstract that I just gave you there on the back page of my handout. You look at the first abstract, and then I would recommend highly that you get a hold of that journal and read the paper. Because what Charlie Cox showed in that paper was that DiCal, if you put it on a exposed dentin surface, that in fact you would get reparative dentin and dental bridging in a couple of weeks, as you've been told in dental school. That's all fine. But you know what? If you put down zinc phosphate on the dentin, you get the same response. And if you put down amalgam on the dentin, you get the same response. Now the question is, what happens when you go into the pulp? Okay, let's make a pulp exposure. Take a monkey. All right, California. I told Charlie in California, we don't have enough monkeys because of animal rights people, so we use attorneys in this state, So I told Charlie. I just spent a week with Charlie in Finland and a couple days in Yosemite last weekend, so I kind of know what Charlie's saying these days. All right, I told Charlie, I said, hey, he told me about the study. He says, okay, you do a monkey pulp exposure and you put in Dical, and the pulp's okay. Give it a week or two and you get dental bridging. But the problem is that the bridge is full of holes. Dental bridges are not solid, normal dentin. They are full of tunnel defects, like spaghetti that goes through the dentin. So then when the Dical blows up later, it gets softened, then you have wide open path for bacteria to get into the pulp, and that's how the pulp dies, all right? So then what Charlie did, he did an interesting experiment. The Dical worked over the period of time he was working, which was a couple months. It was fine. Then he did pulp exposures with amalgam, put amalgam right into the pulp. All right? Well, guess what happened? The pulp died. All right? So then he put some amalgam into the pulp and he sealed it in with a biological seal called IRM as an outer material. IRM, as you group knows, the group here, I'm sure you guys know, this is a phenol. Kills bacteria, kills all kinds of things. Don't ever get it in your eye either. You probably scar your eye permanently. You should have a eugenol-free office besides a mercury-free office. In my opinion, eugenol is a much bigger hazard than mercury. All right.
It is tested.
Oh, is it? Okay, good. I'm glad you guys are onto that. Great. I'm real pleased by that. All right. So anyway, you seal it in with IRM anyway, biological seal. Kills bacteria, kills everything. And you know what? With amalgam in contact with the pulp did reparative dentin in 14 days, just like it did with Dical. So was Dical necessary for pulpal healing? No. What was necessary? A biological seal, no bacteria. And no chemical irritants, such as eugenol. Now, if you put a little eugenol right in the pulp, form of IRM, it'll kill the pulp for sure, guaranteed. Charlie did it.
What did you use for biological seal?
What biological seal? One of them is eugenol. Eugenol on the periphery, not on the pulp. Because if you put eugenol in the pulp will die, guaranteed. But if you take amalgam as a buffer and you put IRM on the outer periphery, then the pulp will be fine. Okay, it's a biological seal. Keeps the bacteria out of there. First of all, it just expands a little bit when it's set, so it makes an excellent physical seal, but if a bacteria got anywhere near the eugenol, it'd be zapped by the phenol effect, right? All right, so then Charlie went on further. He said, okay, we've been told in dental school that phosphoric acid kills pulps. So what he did is he put silicate cement straight into the pulp chamber. Yeah, sure, the tooth died. And then he put silicate cement into the pulp chamber, sealed it in with IRM on the periphery, and guess what? Dental bridging against phosphoric acid in 14 days. Did the same thing with zinc phosphate cement as a pulp cap. Pulp was fine, provided it was sealed in with IRM. So what that means is we've been taught a lot of things in dental school that's wrong. Well, we go down the list. I mean, I have a list of 17 reasons not to use Dical right here in my briefcase from Charlie's lecture in Finland. I wrote them down. Now you got to understand the circumstances here. We're talking at the University of Turku, and the operative dentistry staff there teaches line all dentin with Dical, 100%. Cover every dental surface under every filling or anything with Dical. And here we are going in with the first slide of Charlie's, the 17 reasons not to use Dical. That was my first slide right there. Yes, Ed?
I think it's been banned in Sweden. And one of the Scandinavian countries, they have outlawed Dical.
Yeah, Sweden's really very progressive. Yeah, they've done some quite remarkable things actually. And Sweden's way ahead of the pack, I'll tell you. Finland's way behind. They trail.
Does it have mercury in it? Dical?
No, that's mercury-free. It's calcium hydroxide with a resin base.
Aluminum.
Hmm?
Has aluminum.
Aluminum, well, yeah, I don't know what it has in it besides calcium hydroxide, but you know how you find out? You read the MSDS sheet. That's one thing good about those sheets. Read the MSDS sheet, it tells you what's in it. That's very simple. You know, I can't find much else good about MSDS sheets, but that's one good thing about them. All right. Well, anyway, the best thing you do is throw away your Dical, and you guys have already thrown away your eugenol, so that's good. All right, now let's think about putting in a filling here. So we go in and we cut a class 1 prep and put in a bonding agent. Now, a lot of different bonding agents out there. I have my own favorites, but what you need here is something that bonds enamel and bonds dentin, preferably with the same conditioning of the dentin and the enamel, and preferably with the same bonding agent on the dentin and enamel. Well, when you have that criteria, same conditioning agent and same bonding agent, that eliminates an awful lot of materials. My favorites are two. One's called Photo Bond by Kura-Ray in Japan, and one's called All Bond 2 by Bisco in Chicago. A couple others that are worthy of mention, although certainly not favorites, are Tenure by Denmat. That's a pretty good one. Another one is 3M Multipurpose by 3M, although that's light curable only, which eliminates some of its applications. And another one's OptiBond by Kerr. That one is deficient in that they don't advocate phosphoric acid etching, but if you add the etching, then it works quite well. And because of a patent infringement problem, there's no phosphoric acid in the OptiBond kit, so that's no problem. You just put some phosphoric acid in there. That's no problem. All right. Now there's the inherent problem that happens when you put in a posterior composite. It shrinks by volume about 4%. So it tends to pull away from the margins. Now when you get this margin pull away here, you're wide open for trouble. Now whether this happens clinically or not is questionable, because composite can viscous flow during its polymerization, and it can in fact remain in contact with the enamel during its polymerization. So whether or not it pulls away is questionable, but if it in fact bonds to the enamel, you could conceivably break enamel rods, because we calculate up that the polymerization stresses there are about what it takes to cleave off rods. That's why in Fusayama's textbook you'll note that this is not the cavity design. He has a chamfer up here, chamfer halfway through the enamel, end onto the rods right here, because end onto the rods you get a much, much better bond than if you do vertical like this. So again, Fusayama's book is one to really take a good look at. Now, Kulzer Company's onto the right approach here. They say the instant grip is definitely required. Yeah, they're right. If you don't have a bond on the if you don't have a bond on the enamel and dentin, at the time you polymerize the composite, then all bets are off, because you're not going to get a good seal. Okay, so the timing of that bond is another critical issue. Now, if any of you are using a bonding system where you cure the enamel bond at the same time as the composite, you've got big problems, because you can't possibly cure the bonding agent through the composite before the composite begins to shrink. That's physically impossible. And one set of directions that advocated just that was Gluma. Gluma number 4, you put that on and you cured through the Luma-4 composite, and the Gluma wasn't polymerized yet. All right, so anyway, that's a big problem. And if you have the Gluma system, according to Bayer's directions, that's basically what you have. All right. Now, the only thing that'll save you is the instant bond, the instant grip. And then what you need is elastic stretching of the composite to hold it in contact with the tooth. Now, that will occur to some reasonable degree on some systems, as long as the bond strength is there. But it's an inherent problem we have, and it's one that we've got a problem. We've got the composite shrinking away from the prep, and we really ideally should reverse that. So the clinical consequence is this, that we get these open margins like this. Now this is 2 years out. This is an opaque composite called P50 that comes in nice shades for dog teeth. All right? But it has pretty good wear character. That's why it wasn't on my recommended list there. But to be fair to the material, it actually does wear about the same as Herculite. If you can get by the shade match problem, well, P50 is a reasonable kind of thing to use. I have no problem with that. Now, I'm not about to tell you that that's a margin opening due to composite bond problem, or a margin opening due to cleavage of the enamel rods. I really don't know what it is. I'm not sure. But that is the clinical consequence of some kind of contraction problem. Now, if we were to go back at placement time of that filling material there, re-etch the margins, okay, re-etch all the way around, and put in a penetrating sealant, one that would penetrate a very small defect that's even smaller than what you see there. Kind of like an occlusal sealant, except it isn't an occlusal sealant. It's a water viscosity penetrating resin. Here's the kind of a result you can get. It's the same patient, the same ugly P50 at 2 years, and there's the margin. You can sort of see it there. Now that filling took about 1 or 1.5 minutes longer to place than the other one did, because what it involved was going back, re-etching the margins after the final grind in, re-etch the margin with phosphoric acid, wash it and dry it, and then put it on a penetrating sealant, one that would penetrate down in there. Now, ideally you do this under rubber dam, but the problem is then you check the occlusion and then you end up grinding a little bit. So Ideally what we do is we seal the margins first, take the rubber dam off, grind in the occlusion, then seal the occlusal last, and then you have the best of both worlds. The product that'll do that the best is called Fortified by Bisco. That material there is capable of penetrating a very small mystery defect, one we don't quite understand. Now, if you use occlusal sealants, they're too high in viscosity and they don't seem to do much good in that regard. So this is a unique product so far as I know. The basis of the chemistry is urethane dimethacrylate, which is, of course, a low viscosity diluting monomer, usually put in other composites to thin them down a little bit. And you put it on there, and it just gives a hell of a difference in the result. The other thing that just to mention to you, during the first year of clinical service, this will reduce the wear rate by about 50%. But during the second year of clinical service, makes no difference in wear rate. That tells you it's a very small surface defect that's sealed. Yes?
Is this used on the occlusal surface only, or box?
No, used on every margin.
Every margin?
Yeah, and on the occlusal, it'll cut the wear rate 50%. If you think that 50% of 25 microns is significant, then go ahead and put on the occlusal. Can't hurt anything. I mean, it's not enough to worry about, in my opinion, but.
This is a non-filled
The unfilled sealant, yeah. If it's filled, it wouldn't penetrate that defect. Furthermore, it's a low viscosity unfilled sealant. It's not BIS-GMA. BIS-GMA or Tegma or HEMA is too thick. This is urethane dimethacrylate with a solvent in it. Most likely alcohol, although I don't know what's in it exactly. But it's urethane dimethacrylate based. Okay. Makes it water thin. It's very, very thin.
Raymond, if you get this on the marginal ridge, with the
Right.
adjacent tooth,
No, you never feel the occlusion. No, it's too thin. It's less than 4 microns thick, so you'll never feel it. No way. You can't feel 4 microns intraorally. Can't. You put 4 micron film on something, you can't feel it. It's within the movement of periodontal membranes. So no, just put it anywhere. You can put it on adjacent tooth, it won't hurt a darn thing. Matter of fact, you can use this as an occlusal sealant, but the problem is you can't really detect it because it's down in the depth of the groove and you really can't find it. It doesn't make that little meniscus like occlusal sealants do. Bisco. Bisco, yeah, Bisco. It's easy to call Bisco, 1-800-BISDENT, B-I-S-D-E-N-T, BISDENT. Easy to find. Okay, now here's what we're going to do. We're going to turn the shrinkage around, make it go the other way towards the tooth. That makes a big difference, doesn't it? Doesn't shrink towards a little ball, it shrinks towards the tooth. That's exactly what we want. We get viscous flow during the polymerization. Now, to initiate the polymerization at the tooth, we can use one of 3 approaches. We can use heat, because the tooth is a little bit warmer than the environment, so that the initiation will in fact be there, although that's not a dramatic difference because the tooth isn't all that much hotter than the room. Fusuyama points that out in his textbook, that the heat does make a difference, and he's right, it does, but that's not quite enough to do the job. If you could get the light to come off the tooth, then that would work great, but I don't know how to do that yet. We're working on a fluorescing bonding agent, which in the future may in fact do that, light up on the tooth and make the tooth interface set first. We think we know how to do that with an argon laser, but the problem is it kills tooth right now. It's biologically unacceptable material, fluorescer. But the concept is there, huh? So anyway, maybe in the future. All right, so right now we're going to have to use chemistry. So I'll put a hot catalyst on the tooth. All right, there's the catalyst that I recommend based on clinical experience. This is one that's well documented in the Japanese literature and to some degree now in the American literature. A lot of papers on it. If you want to do a literature search on it and you can read Japanese, the authors are Enokoshi and Hasoda. Those are the 2 that have done most of the stuff. Now the catalyst in photobond there is a very unique one. It's one that's really very active. And one of the secrets of why photobond bonds dentin so well is in fact this catalyst here really polymerizes the material very well. So what happens is you put the photobond on the dentin and enamel and you have a surface scum there that's air inhibited like most bonding agents are. And that air inhibited scum then is liquid even after you cured the material, just like most of the BIS-GMA bonding agents that everybody knows. Well, that surface scum then is very high in catalyst, so when you put a composite down against the scum, the catalyst in the photobond sets off the composite and initiates polymerization. It's kind of like a chain reaction. Once you initiate polymerization, it tends to move away from the interface. So that's a very satisfactory way to do it. Then what you do, you use what Fusiyama told us to do, and that is use an auto-cured composite. And when you use an auto-cured composite on the photobond, you get the initiation on this interface. It moves towards the interface. And even though Fusiyama has, he likes auto-cure on the occlusal, I don't particularly, because I can't control the shape as well, and I can't control the surface polish and finish as well. So I'm using a light-cured composite as an overlay, and that seems to have the advantages of both systems. Now the other problem we have as clinicians, if we're going to put in composites, we want to have decent looking contacts, and that's really tough to do, or has been tough to do. Poor contacts that are either too light or not anatomically correct has been a major problem. So what you've probably tried to correct this deficiency in the past is like a thinner matrix, like the Ho band or the Dixieland band or some other mystery band, and you found it didn't make any difference. Or you've tried the soft matrix. Now that actually does work. You can take a soft matrix, put it in there, burnish it, burnish out a contact. The problem is you burnish what's called a wraparound or a little donut-shaped contact. That donut is not satisfactory clinically. And if you're using a soft matrix, I'm going to challenge it. You look at your x-rays, and if you can find consistency in your contacts, I'd love to see some of your x-rays. I bet you got these little wraparound jobs that are clinically unacceptable, clinically fully unacceptable. Okay, so you really evaluate if you're using a soft matrix. If you got a technique that works, I'd love to see some of your x-rays. And the other problem is that the heavy wedging, that is that what they told you in dental school, wedge a little bit more to make up for the thickness of the band. That's a major mistake, and I want to show you why. Now, if you put in a filling and you're striving for a proper anatomical contact right here, we all know where it's supposed to be, but only rarely do we place it there. And then you put in a matrix, right? Well, everything's pretty good right now. And then you wedge. Here's where problems are. See what the problem happens? Where the problem is? You wedge, 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 and what you do, you create an artificial space in here. This space is a thickness that's bigger than the thickness of that band. So what happens is the contact starts climbing up the marginal ridge. Just like discount crowns, they have their contacts up there, right? Yeah, they do, because the technician doesn't take the time to place the contacts in their proper place. So, okay, you've got a misplaced band, and the more you wedge, the more that contact climbs up. Okay, because you've over-wedged more than the thickness of the band. Now, again, if this is a soft matrix, you can burnish it, but you burnish what's called a wraparound, because anatomically you can't get in there and burnish the contact properly. It can't be done clinically on a consistent basis. It just can't be done. You can do it. I'd like to see your results, because I want to know what you're doing. So what you end up with then is an over-contoured filling that's way up here someplace, and the height of contact is right there, but in fact the contact should have been down here. So what you end up doing, you cut off that surplus stuff up there, that's composite. Well, I guess you disc it or burr it off of there, ding the adjacent tooth a couple places, all right? And then you ask you ask your assistant for some tape, not floss, please, tape. And you go through there, and yes, we got a light contact, right? And then you say a little prayer, because you over-wedge the hell out of the teeth anyway, so they're probably going to drift together. Now, if it's a spouse or another dentist or an attorney, they won't, all right? And a plain old patient, they drift together. I have a practice that's limited to non-dentists for that reason, Actually, I have a lot of dentists, patients of record, but I'm thinking about making a new card that says, practice limited to non-dentists. Give it to them as a joke. All right. Now here's the answer. There's a sectional matrix in bitine ring. Now a lot of people throughout the world think I invented this thing. That's just not true. I didn't invent it at all. I uncovered it from the literature. The guy that invented it is Dr. Bud Meyer in Palo Alto, California. And that's why it's called Palo Alto Dental. And Bud invented this thing about 30 years ago, and he couldn't sell it, because that was the days of amalgam, and amalgam is reasonably forgiving in terms of contacts and all that. So Bud just wasn't successful. But I read the literature a few years ago, and I read this paper, and gee whiz, that thing sounds like it ought to actually work. So I tracked it down, and sure enough, it does work. Bud Meyer's got a beautiful system there. The way you buy it, you can call Palo Alto Dental Palo Dent in Portola Valley, California. I don't know where it's up by Santa Cruz somewhere. Or if you want to, you can call his dealer called the Tin Man in Redding, California. It's called Tin Man, Redding, California. They have an 800 phone number. That's probably a little easier way to get them. T-I-N, Tin Man, as in tin plating. Those are guys that sell tin plating devices for
What?
intraoral gold. Tin Man. Yeah, I can give you the phone number if you want. It's in my pack here.
MAN?
Yeah. I'll just give you a phone number if you want here. Find it. It's area code 916. Okay, 243-6934. That's the easiest place to get them.
6934?
Yeah, 6934. That's the easiest place. Sectional matrix, yeah, just tell them Bud Meyer System. They know exactly what you want. They're the biggest dealer in the United States by 10-to-1 margin over the nearest competitors, so they know exactly what you want. All right. Let's take out that ratty-looking amalgam for whatever reason you choose to take it out. You guys might have a different reason than me. That's fine. I got no problem with that. Just take that damn thing out of there. All right, now we got a prep, and I'm not here to talk about prep design. I could be, but I'm not here for that today. Ed said, hey, keep it on this other subject here, so that's fine. Now, does it look okay or not? You ready to put a filling in? No. Not ready to put a filling in. What are you going to do? Round it up a little? Well, that's probably a good idea. Actually, to bevel the occlusals, not a bevel, but put a chamfer on the occlusal. Yeah, reverse chamfer. That would be better. I agree. Well, here's what I'm really worried about, though, is the caries out of there. You guys say the caries out of there or not? What do you think? Can't tell. Damn right, you can't tell. That's right. That's a sore subject. But after all your dental training, a cariology in dental school for 2 semesters of a sleeper course, what'd you come away with? How do you remove caries? Slow speed. Yeah, I know. Hard to tell. Yeah, I know. It's called caries detector. That's a missing link. This is mandatory for every filling you put in the mouth. You cannot do dentistry without this. You can't do it. You're not doing optimal dentistry, because if you don't use this material, you're leaving in caries a substantial fraction of the time. I assure you. I assure you that's true, because British dental students and their operative instructor, all right, British dental students and an operative instructor assess preps as caries free. And you know what? When you use caries detector, they got dent and enamel junction caries, and 57% of the preps assessed caries free. Now, you know what they call that among this group right here? Called recurrent caries. Damn right. That's what keeps y'all in business, all this recurrent stuff. That's not recurrent stuff, that's missed stuff. Don't let anybody fool you. If you put in a properly bonded composite or amalgam filling that's properly bonded, leak-free, it's not going to recur. No way. No way. We haven't had a recurrent caries in my office since we started bonding everything. We bond all our amalgam, we bond all our gold, we bond all our composite, and bond almost all our ceramic. There ain't no recurrent caries. There it is, caries detector, Kure, Japan. And it's also sold in California. It's called Caries Finder. It's Danville Engineering, and that same source that sells Bitine rings has it in stock, or you can get it direct from Danville Engineering, Danville, California, either way. Called Caries Finder, the American clone of that. I got the whole slides series here on caries detector, but I don't have time to show them, I don't think. I'd be happy to do it if you can find me some time. All right. Yeah, okay, wash off the caries finder, and then you dry it out. Now this is a dry field technique we're doing here. We're not using wet field with all bond. This is dry field clear fill. So that's what the prep looks like there. Now, take a look over here at the adjacent tooth. There's caries finder in there. There's bacterial plaque in there. There's recurrent caries below the enamel right there. You can use it as a diagnostic tool in addition to detecting caries. Caries detector will detect caries reliably, but it will also detect plaque. Okay, it's a dual-purpose material. Now, but you cannot use plaque detecting solution like you have in your office already for detecting caries, because it's not histologically correct. So you can't do it the other way. The reason is that the red molecule that's used in plaque disclosing solution is too big to penetrate the denatured collagen of caries. It's too large a molecule, so you can do it the other way. You can use the caries finder to detect plaque. That's no problem. But you can't do it the other way around, because the molecule size is too big. Okay? That's in Fusayama's textbook again. All that stuff's right there. Okay, now we're etching dentin. That's phosphoric acid 37 going smack right on the dentin. Now in dental school, you were told that that patient would die if you did that. You went to a conservative school, you know, the whole patient would die. And if you went to a progressive school, only a tooth, I guess, would die. Turns out that none of that's true. Phosphoric acid doesn't kill the pulp, even if you put it direct on a pulp. We put it on a pulp all the time. We put it right on pulp exposure. You don't believe me? Take a look at Quintessence International, April '93. Take a look at the cover on that one. That's a direct hit right on the pulp. Okay, if you guys aren't onto this, you're really onto the wrong, you've been missing out on something, you know, really. Okay, you're on the wrong technique, believe me.
Stop the bleeding?
No, it doesn't stop the bleeding. It promotes bleeding. Phosphoric doesn't. You have to stop the bleeding with superoxal. Right on the pulp. Smack. Boom. No problem. Won't kill the pulp either. If you think it'll kill the pulp, you're wrong. Dead wrong. It will not. You come to my seminar, I'll give you documentation on all this. We got it. We got the references and refereed hard journals like Quintessence and all those. It's true. Yes, Ed.
How far does the superoxal penetrate the pulp chamber?
Damn if I know, Ed, but it's taken up the bloodstream. That's been shown. Huh?
It just coagulates it.
Yeah, it does. Yeah, I believe so.
Okay.
15% hydrogen peroxide is my recommendation, not straight superoxal. It's a little bit more than necessary. 15% peroxide. Peroxide's not good for you, as all of you know, of course. And it's not good, so you want to keep the quantity down, minimal, huh? All right, hydrogen peroxide is bad news. But if you use the 15% just in a little cotton pellet and dab the pump, the pulp will stop bleeding, and the tooth will be alive and be well. So that's it's a risk, because hydrogen peroxide is not good for you. But on the other hand, the benefits here associated with the risks are tremendous. You're going to save the tooth, So I have to do that. Yeah, you just take superoxal, which is 35% peroxide, and make it half and half with water. And I hope all of you know you don't buy superoxal from Union Broach for $15 a little thing. You go to a chemical supply house and ask for pharmaceutical grade peroxide, 35%, USP peroxide, $10 a gallon. I guess everybody knows that by now, huh? You didn't know that, you better come to my seminar. I'll save you some money. Show you how to make your own etchant and everything else. Okay, go ahead and wash off all that phosphoric there. Wash off the salts from the chemical reaction, the phosphoric and the dentin and enamel. Now the phosphoric only decalcifies. It doesn't affect the collagen. So there's where we're going to start to divert now. We can't do it today because of limited time, but certain bonding agents will in fact attach collagen. Certain will penetrate through collagen, and certain just would rather not have the collagen there. So you can deal with different bonding agents under different conditions. You can remove collagen, for example, with sodium hypochlorite. 10% hypochlorite will take the collagen off and allow a better bond for a lot of materials. In this particular case, we're going to kind of ignore the collagen, hope it isn't around, although it is. So we're going to dry that off there. Okay, we're going to dry off the ethanol. Okay, drying off the acid. Okay, now we're putting on our photobond. The instant grip is definitely required, so there's photobond being polymerized. Now that bond strength on the dentin there with photobond is about half the enamel bond value. And half the enamel bond value is more than adequate for an auto-cured resin system. If you're using a light-cured resin system, that's pretty marginal. So, if you're using light-cured resin system, you might want to use a stronger bonding agent like 3M multipurpose or All-Bond or Metabond, one of those. And then we take the Bitine ring sectional matrix, get it ready to go here. Here goes the matrix in there with a little wedge to wedge the gingival together. And now I've got my matrix in place. That's the Bitine ring. And please note how that sits over the tooth there. It's real important. Because if you put the ring vertically above that wedge, then unfortunately it won't engage a lot of tooth and it comes off pretty easy. So you let it be aside the wedge like that. And that holds the matrix down on the tooth quite nicely. But the other function of that ring is that you have a spring. This spring is pushing in between the two teeth, tending to push the teeth apart. And you get separation, get clinical separation. But because that's a spring, you're doing orthodontics during the procedure. So the longer you leave that thing on, the more they're going to be spread apart. Now, clinically, if you leave it on for about 5 minutes, you'll find that you'll get about the separation you're looking for. Contacts are about right or perhaps a little on the tight side. If you leave it on 10 or 15 minutes, you can have contacts that are genuinely over-tied. Now again, another quick look at that. Just a little clinical tip for you. When you put the Bitine ring on, always put it on the side you wedged from because it'll push this, no, I said that wrong. Always put the wedge on the side where it's the widest prep. Because you see the wedge will push the Bitine ring out away from the prep. And if you wedge from the other side, for example, you'd push the Bitine ring out this way, but this one might collapse into the prep. So you always want to wedge from the side that has the widest extension. If you do that, you'll get a good result. Yeah?
When you have a prep that's extended more buccally or lingually, how do you keep that damp
Well, if it's more buccal or lingual than, if it's more buccal than about there, then you need to use some Mickey Mouse matrix band because this isn't going to work. Or it's time to do an onlay with concept maybe. Yeah, it's not for every prep, but it works for a lot of them. Okay. Yeah. Now we're going to inject in an auto-cured resin here, right down against the photobond. The auto-cured resin, there are several different brand names that would work, but I have a very strong recommendation, the one that's by far the best, because it was designed for this procedure. And you can use a lot of them. For example, Clearfill SC is a very good one, but it doesn't work as well as the one you'll see. This one right here, Bisfill 2B. And that's what I would recommend because that one was tailored specifically for this technique. This is radiopaque, injectable. It flows very well through a needle tube by Centrix. It sticks to the photobond quite well without any bubbles. It flows around in there almost magically. In fact, a lot of doctors think it flows too much. That's because they're used to using condensable composites. But anyway, I find it perfect. It better be because I designed it, but it's to my satisfaction. We went through about 20 different prototypes until we found one that was completely to my satisfaction, and then I told Bisco that's the one. Stuff's selling like hotcakes, you know. I wish I had gotten royalties on it. I'd be getting a lot of money, but I didn't.
Compatibility and substance that's inside of it.
Well, it's BIS-GMA based. It's got 3 kind of fillers in it. It's got quartz, it's got a barium glass, and it's got microfill. Do any of those things bother you any? Now, what's the toxicity of amalgam compared to composites? Camphor quinone, barium glass, silicate, BIS-GMA resin, urethane dimethacrylate resin, tegma resin, hema resin, some peroxides and some amines. And they wear at 25 to 50 microns a year. Now, what's the toxicity of those compared to silver? Yeah. Go ahead, Doc. Do you have a question?
Yeah.
Okay.
We use that all the time. The new stuff we find, it's too viscous.
Oh, the newer batches, the higher viscosity. Yeah, you get the new batch. Yeah, I know.
So
They're making 2 kinds now, I think. They're making a new one that's a little stiffer and a little faster setting. You may have gotten a hold of that.
little faster setting.
Well, now see, there's a difference of opinion. Some doctors want it to go faster, some want it to go slower. Some want it higher viscosity, some want it lower viscosity. So what they did.
Well, it depends on the cavity prep. So
Yeah, of course. Yeah, I know. Well, this is the one that I designed.
That's the slower setting.
Yeah. Yeah, how slow? 3 minutes from the start of the mix, right here. Oops, no, I'll show you, but it's 3 minutes. I'll show you the time, okay? But yeah, there's a difference of opinion among operators of how fast it should go and how viscous it should be. So what Bisco's done is they've introduced a new one that's a little bit thicker and a little bit faster because there was a high demand for that. I know why, because the doctors want to go like real fast and they don't like change, you know. There's only one kind of humans that like change, and that's wet babies. You haven't figured that out, okay? So they want it thick to feel like Herculite or something. Well, that's exactly what you don't want because you want the stuff to flow down against the photobond without voids. So against my best judgment, I told Bisco, well, go ahead if that's what the doctors want, and they aren't going to use Bisfill 2B, then make one to satisfy them because that'll be better than using Herculite or something stiff in there all by itself. So I advised them, go ahead and market it, whatever they want, but this is the one that I would prefer. Okay, I'd like to see it go a little faster, but other than that, I like the viscosity.
Are both viscosities available?
Yeah, both viscosities, as far as I know, are available. Yeah. I would ask them for Bisfill 2B original if I was you. Start from that point, and then if you need a higher viscosity, well, go ahead and switch. I'll show you how to tailor the set time here in a moment. Now, here's another thing you need to do, make a decision here. You can layer heliomolar directly over the unset Bisfill 2B, the liquid, and push it with the helio right at the tooth. That ensures you have no gaps, no porosity, no defects. The trade-off is that you get Bisfill up on the occlusal where you really didn't have it in mind. That's where you didn't really want it there. So the other thing you could do is you put the Bisfill in there, let it set completely, let it hard set, and then after it's set, come in and lay the heliomolar over it. You can inject in helio out of just a regular syringe. That'd be fine. There's an option there, depending on what you'd like to do. Either let it set hard or push down with it. I prefer pushing it. Yes, Ed?
Would you put any unfilled resin in that sandwich?
Not necessary yet because the Bisfill 2B will stay oxygen inhibited on the surface quite fine until the helio hits it. So there wouldn't be any need for an unfilled resin sandwich in there. It's fully oxygen inhibited. Yeah.
What is the, I mean, we've been involved with this technique for a long time, actually since we heard you in I think Melbourne about a couple of years back.
Mm-hmm.
But look, what's the situation of having bisphil on the surface? I mean, how hard is it? Is
Okay.
it comparable to your helium-80? And if so, fine.
Mm-hmm. Yeah, I agree. Well,
when are you going to invent something so we don't have to set anything with a light cure? You know, we can just put it in.
yeah. Well, the bisphil on the surface is mostly a cosmetic problem. It's fairly opaque white. We made it that way so that we could see it as a liner. You see, it was designed not to be tooth colored because we wanted to know where it was. That's exactly why. So if you have it on the occlusal surface, we don't have intraoral wear data from Leinfelder or anything like that, but I would predict based on the filler content that it would be pretty close up there. It's okay on the occlusal. I wouldn't say desirable though. If you get it up there, don't worry too much. It's okay. But it's going to be kind of funny looking opaque white, so that's not so good. All right? Not so good there. Anyway, you make a decision at this point to whether you push on the liquid bisphil or you leave the bisphil set and then layer it. Take your pick. And you should actually light cure the bisphil the helio only after the bisphil is fully set. Okay, you should not disturb the set of the bisphil in any way. So put the helio on the wet bisphil and then just wait for the bisphil to set, or let the bisphil set and then place the helio. Either way. Go ahead and light cure the helio. That's fine. Appropriate time. Now here's the setting time. Bisphil 2B, as designed originally in San Leandro, California, which is room temperature 72, sets in 3 minutes from the start of the mix. Full polymerization, which means you have about 1 minute and 3/4 working time where you don't see any gelation yet. The newer version goes quite a bit faster. Well, that's okay if that's what you want, but the bisphil 2B can be tailored to go faster or slower depending on the ratio of the mix. So you can make it go a little bit slower if you wish by increasing the catalyst. Now you please notice that that's backwards from logic. Okay? And the reason for that is the catalyst isn't what sets off composites, it's the initiator. The initiator is in the universal, complete with an inhibitor. Very complex chemistry here. The base contains initiator and inhibitor. The other one contains catalyst. The catalyst overcomes the inhibitor, which lets the initiator polymerize the composite. Now, I don't want to go on and on and on with organic chemistry, but you see that's why the organic chemists label it that way. It's the initiator that makes things go faster, not the catalyst. It's all goofed up in our nomenclature, but that's all right. Yeah?
What are you doing when you have the interproximal roll around at the facial and it's maybe a bypass
Oh, okay.
facial?
If the interproximal goes around the facial and you don't want an ugly line there, what you do is you take a little Herculite or Helio, pack it up against a matrix band, staying off the dentin, go ahead and cure it, and then inject in bisphil behind it. And if it's that wide of a prep, you shouldn't have too much trouble doing that, you know. It's a little tricky, but it'll work out okay. You can just inject in some Helio in there and then push it with some kind of metal instrument and then go ahead and inject behind it, and that's fine. The main thing is that the dentin be covered 100% with the auto cure. That's what's so critical. And any margins that are off enamel, of course. Okay, that's really, really, really critical. Okay, then you take out that matrix band, and first time you do this, it's quite amazing. You think that you can lift that band out very easily with cotton pliers. It didn't come out with the cotton pliers. You need a hemostat at minimum to release the band, because very tight contacts. Now there's one there that has all kinds of technical defects, so it makes a good slide to show. It's not a good one. This has a lot of flash down here, which is undesirable, and the occlusal actually is pretty good. And it has a little flash of Helio out here. Well, it's not been etched on the facial, so that should come off easily. That should just basically be priable. Cut that off. But here we might have a problem. If we use a rotary diamond here, we'll get sensitivity because we open dentinal tubules. So the best thing to do in that area is a number 12 blade. Just cut the stuff off. And bisphil was made such that you can cut it with a blade. That was another design criteria. The rocks aren't so big that you can actually cut it with a blade. And then on the occlusal, a strong advantage of Helio is that you can polish it quite acceptably with a 12-bladed sharp carbide, preferably brand new. Now Herculite and some of the others unfortunately don't cut very well with a 12 blade. Then you disc as appropriate, disc it out and get good contour. Now Helio will polish with Prophy paste to a pretty good finish. Coarse Prophy paste, and then of course change the cup or wash the cup thoroughly in fine Prophy paste. That's a pretty good finish, and I would find it clinically acceptable. If you want to take it to another stage of polishing paste, well, that's fine, no problem. But you have to ask yourself in your practice now, if you're going to take it to, say, Prismagloss as a final stage, what about your dental hygienist? Do they routinely use Prismagloss, or do they rip through there with coarse Nupro Prophy paste? In my experience, they rip through with coarse Prophy paste, because coarse Prophy paste outsells fine Prophy paste by 25 to 1. Okay, so now if your hygienist is going to go through there with heavy polishing paste at the recall appointment, why bother with the Prismagloss at this stage? I mean, I don't see any particular advantage there. So do what's right. I mean, what's right, in my opinion, is to offer Prismagloss as a final polish at your hygiene appointment. For a price, of course, because it takes extra time. All right? That doesn't necessarily put you in the Delta UCR if you do that. But that should be an optional service. It's one I think you should offer your patients, that upgraded quality cleaning that costs a little bit more than the insurance is going to buy. Call it an upgrade. That's what we do. You want the cosmetic upgrade? We've got it. Okay? Yes?
Where do you get Prismagloss?
What's that?
Where do you get it?
Prismagloss is a caulk company, so any caulk dealer. But in regard to that kind of thing, Reality here is a source of a lot of alternative materials, and that's why I recommend Reality very strongly. I brought some complimentary monthly newsletters over there on the desk. Reality will give you the different brands of polishing paste and tell you which composites they work on, how much they cost per gram, and how much they cost per use. This kind of information isn't anywhere else. It's only in Reality. This is like Consumer Reports. They don't take any paid advertising, so if they tick off somebody, they don't care. It doesn't make any difference. All right? You know, there was a paper recently that I reviewed in here. I said, yeah, here it is. This is a great contribution to the Journal of Non-Reproducible Results. That's what I said. Didn't jive with anybody else, you know. And but we thought we better bring that to people's attention, because if if somebody read that and hadn't read the literature, you'd think, well, maybe that's the answer. But my golly, it was completely out of harmony. What's that? Reality Publishing in Houston, Texas. But there's who pays for it? You do. Because it's only by subscription. It's $125 or something like that a year. It's completely self-supported by subscription. Even the editors don't get anything except a free meal a year. Not one of the editors, but 27 of us now. We get a free meal a year, and that's all we get. But the reason I do this, I don't have a lot of spare time these days, but the reason I do it is I get a stack of literature about an inch thick about every other month of pertinent stuff that's out there that's been screened, Xeroxed, and sent to me for evaluation. And it's an incredible source of technical info that you can't get any other way. So that's a good trade-off. For doing that, I'm an editor of Reality, and it's a reasonable trade-off. All right. There's a complimentary newsletter over there on the desk. Okay, now there's a contact roughed in. It's not perfect. Here's how you enhance that contact zone if necessary. This is a GC, means General Chemical Metal Strip, 1000 grit GC, made in Japan, sold by most of the major dental dealers. GC metal strip, 1000 grit. Now that one there is a 600, but use 1000 because 600 will break the contact. Now, those of you that think that posterior composites can't hold up, take a good look. This group here, I imagine you know that composites can be pretty good. That's as finished. That's clinically just finished. Now I'm going to show it to you 3 years later, but take a good look at it right now. Okay, take a really good look at it. Be critical as you want to be. All right, look at that patient. What kind of patient did I pick for you? Tells you something, huh? Gingival tells you something, doesn't it? Now, look at the filling though. Look at this. Hey, that margin doesn't even tick. Look at the discoloration. There isn't any. Huh? Look at the polish on the Helio. Look at that. You can't tell it from enamel. All right? And there's a margin right here. It's not there. It's here. On a Bruxer. Clencher Bruxer. 3 years and 1 month later. Not too shabby, huh? I show that for people who think you need amalgam. Huh. You don't need amalgam. You don't. Okay? I use amalgam, but I don't need amalgam. Okay? Now here's the route I showed you here. Etching solution, okay, photobond, because photobond catalyst is one way to set off the bisphenol 2B. This is my favorite way to go. Bisphenol 2B, because it's auto-cured and it's very sticky and very runny, and then heliomolar, because that's a long-term favorite of mine. But to acknowledge another excellent system that will do the same kind of job, that's etching solution, all bond primer A and B in a wet field, not a dry one. This you leave wet, and by the way, don't ever, ever let it dry out between etching and priming, because if you let it dry in here, the all bond is almost worthless. You get sensitivity. You cannot remoisten a dried tooth. It cannot be done. It will not restore. It will not go back to its original state. That's brand new information. That's hot information.
What was that again?
Don't let the damn tooth dry out. If you're using all bond, you've got to keep it wet 100% of the time between the etch and the prime, because if this dries in this stage here, you cannot remoisten successfully. It will not happen.
What about photobond?
Photobond is dry field. Dry, 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 dry. Drier the better.
How wet do you want to keep it?
Wet.
Saturated?
Saturated, wet.
Cavities, 12 water.
Wet. Wet gauze is fine. Yes, wet. Yes, wet.
Bond has dentin cleanser.
Well, dentin cleanser, if you want to use dentin cleanser, that's chlorhexidine gluconate 2% aqueous. You put it on here right on the wet dentin, okay, and use a lot of it because it's cheap, and just displace the moisture with wet chlorhex, 2%. Now, whether it does any good or not is highly questionable. It has no effect on bond strength.
So why do they market it?
Well, because everybody's into, well, not everybody. Here's a good example. Everybody's into fluoride release. I bet everybody in this room is not into fluoride release. You got it. I think it's contraindicated myself. And you know what, Ed? There's not a damn bit of literature. There's not a damn bit of literature that justifies the use of fluoride release. There's no karyostatic effect of fluoride release. That's a crock. All they've ever shown in literature is that it releases fluoride, but they haven't shown it does any good. And on the contrary, I think a lot of you could probably show that it might be a hazard. There's a legitimate question there.
Kills live cells.
Well, yeah, it does a lot of things, but that's not my expertise now. But the thing is, the fact it's never shown to do any good is my point. This is a bunch of baloney. All right? There isn't anything out there. Glass ionomer, same thing, by the way. Yes?
Is photobond light cured, and how does Scotch Bond do?
No, the photobond is a dual cure. It will light cure and it will cure in the dark. Scotch Bond, I call Scotch Guard because they used to guard the smear. Now that they etch with it, now they're not etching enamel properly, which is very interesting because they have a psychological etch called maleic acid. It does not etch enamel properly, which is quite interesting. Psychological etchant, because everybody, even our Aussie over here, knows that maleic acid doesn't kill teeth, right? Rory Hume never said that in Australia. He just said phosphoric killed tooth, right? That's right. Now, by the way, Rory's using phosphoric to etch a dentin now.
Don't mention Hume to us, Steve.
I know. Well, I quote Hume in Australia, 1991, August 91. Total etch, total seal, total bullshit. That's after I said total etch, total seal, total success a week earlier. But Rory's etching dentin now. He's come around because he's looked at the data, honestly looked at it, and changed his opinion, which is fine. I respect that. Yes?
On the etch, are you still using liquid and not gel?
I'm using liquid, but I don't think it makes a hell of a lot of difference. See, the gel is mainly for the dentists that want to not etch dentin, that want to put the gel on the enamel. The latest data says, and this is Bob Erickson's paper, 1992 IADR, Bob Erickson says that when you etch the enamel with 3M etching gel, the blue gel, and you wash it off, you wash it past the dentin, of course, the dentin permeability goes up by 40% when you wash the gel off the enamel, which means you're stripping smear off dentin. So you see, the idea of etching enamel and not etching dentin is a desk plan. It can't be done in the clinic. That's nonsense. Even if you use gel on the enamel, you still can't do it.
You used to have two slides, one of a gel and one of a...
Yeah, I used to have gel. I used to have them with me, but I only have an hour, so I can't do a whole lecture here now. Yes?
Does Durolon liquid remove the...
Remove the smear? Yes, it does, Doc. Durolon liquid will take off the smear, but it won't pull the smear plugs out of the tubules. It leaves some smear debris down in the tubules. Now, if you want to leave smear plugs in there, then Durolon liquid will, in fact, clean the dentin. Yeah, it will.
What are the pros and cons of leaving that in there?
Well, it's analogous to this. Here's the best analogy. If you believe that cotton is a good plug, then leave the smear in there. And if you believe that concrete is a good plug, then put resin down the tubules. It's analogous to the difference between cotton and concrete. Okay, smear is to resin what cotton is to concrete. All right? trying to plug up a pipe that sprung a leak at home. You got stuck some cotton in there, are you? You might get away with sticking concrete in there, maybe. Maybe. It expands a little when it sets, right? Yes?
Would you comment on the metaphor system research that shows the hybrid dentin layer being more resistant to hydrochloric acid than enamel?
Oh, it's true. The hybrid layer, not just with 4-meta, however, the hybrid zone that's created between 4-meta and decalcified dentin, and you know, by the way, with 4-meta, they call the green stuff is called activator. That's bullshit. That's citric acid and ferric chloride. Citric acid, you know, like decalcifier. Okay, so they're etching the dentin. All right, so you etch a dentin and you put in 4-meta in methyl methacrylate with TBBO catalyst, triene-butylborane, and then you get a hybrid zone, and that resists the acid dissolution. But so does photobond, so does Albond in the same analogous manner. The chemistry is just different. And in regard to triene-butylborane, if you want to test your catalyst with Metabond, all you do is you take your catalyst and you put a drop on Kleenex, and if it doesn't burst into flames, you've got bad catalyst. It's old stuff. It's pyrophoric. It should at least smolder. And under ideal conditions, it would burst your Kleenex into flames if it's a hot, good, proper catalyst. Okay. If you don't have that activity, I'd put in a couple drops of catalyst. I wouldn't use one. I'd use 2. Maybe 3. Because you don't know how active the stuff is. You don't have polymerization. You know, monomers are toxic to the pulp. It's polymers that aren't. So you can put HEMA. You can put HEMA in your eyeball, hydroxyethyl methacrylate in your eyeball. That's polyhema. That's a soft contact lens. But if you put it into the pulp, it'll kill the pulp. When you polymerize it, it's fine. Pretty interesting, huh? You want to polymerize these things. You don't want a bunch of free monomers cruising around. You want polymers there. That's where some of the pulp biologists have made a big mistake. They test monomers, not polymers. And you're not putting monomers in tooth, you're putting polymers in there, hopefully. Okay. Any other questions there? Okay. Yes?
Do you like cure the AB under composites or just under?
Well, in this case, in the case of Albond, they say now that you should light cure this if you're not going to get light to it, say, for example, through this layer. So if you're putting this layer over it and you're light curing this layer, that light will transmit into the AB, and there's no necessity of a separate step of light cure. But let's say that you were going to bond a crown, for example, the primer AB, an opaque crown, maybe a gold crown, then you would want to light cure AB because you're not going to get light to it in the future. Okay, that would be a clinical improvement. Okay, you can do MOD with Bitine ring, no problem. Just put on 2 of them at once because they arc over the adjacent tooth, not the one that's being restored. Okay. The only thing I can offer as advice based on experience is that if you haven't actually broken the contact between the 2 teeth, if you haven't actually broken it, then the problem is that the regular sectional matrix won't go through sometimes. It kind of hangs up in there because it's fairly soft. You may have observed this. In that case, yeah, just use ordinary shim stock or a piece of Toffelmeyer or something, and it'll be just fine. Because in those real tight little preps, the anatomy is not such a critical issue, you know. It's the big preps where the anatomy is so important and you need that sectional. Okay. Now here's a couple little slides here, and then I think I'm really out of time. There's what we did when we were developing the Bisfil system, and just give you an idea that this really was based on a little bit of laboratory research here, and not didn't make this thing up. There's Helio and there's Bisfil. See, the Helio shines pretty nice and Bisfil doesn't. So the doctor had asked me a question here about Bisfil on the surface. That's kind of ugly. See, it isn't shiny and it's kind of white, but on the other hand, at least it would be forecast to wear reasonably well based on its filler content. So, you know, it's not a big problem to have it on the occlusal. Okay, so we put in our fillings there. Of course, these fillings here are real long, and this is a very adverse situation. So now what we do, we stain it with caries detector to pick up on any gaps. It's a nice little disclosing solution for gaps and things like that. And you see it's nice and it's closed. It's free. It's got a little plaque out here which we disclosed, but you'll notice that that interface is really remarkably good. And it's just as good on the dentin here in the cervical area as it is on the enamel. Well, that got us real excited. We thought, oh boy, this is going to be a good technique. It's going to be problem-free. Now, a lot of people say, oh, glass ionomers, oh man, those are wonderful. They chelate calcium, the electrons jump off the glass ionomer and, you know, interchange with the calcium. Well, I don't believe all that, but that's what people say. Here is very glass by caulk. Look at the gap right here. This is on enamel, which has even more calcium than dentin. And here's Fuji 2LC. Look at this. Look at that gap over there. Woo! Now what I say about this is that if that gap is there, then how can we have chemical bond like all the researchers are telling us about? See, they tell us that the electrons are going to interchange between the glass ionomer and the calcium. Well, gee whiz, why am I getting a gap if that's the case? I don't understand. It doesn't make sense to me. Something's terribly wrong with that theory. But these are wide open, and if anybody ever tells you the glass ionomer seals well, they are wrong. They're dead wrong. We can show that.
Glass ionomer causes a lot of sensitivity.
Yeah, it causes a lot of sensitivity. Of course it does. And the reason is that it doesn't make a seal.
Right.
No seal, no success.
That's right.
It's the bottom line. If you have open dental tubules that are moving fluid, you have sensitivity. That's a single sole source of sensitivity intraorally. There is no other source. It's fluid movement in the dental tubules. And if you haven't sealed the tubules, you have potential sensitivity. All you have to do is move fluid in there. That's a single sole source of sensitivity. There is no other source. Bond a crown on and it's sensitive, you have open tubules. Do a composite and you have sensitivity, you have open tubules. Do periosurgery and you have open tubules on the root, you got you got sensitivity. All you do is put a resin plug down them, you don't have any more sensitivity. But that's subject for another day, huh? San Francisco, we're a temporary house there.
Work on the root sensitivity?
Fortify will not work on root sensitivity because Fortify will not bond into collagen in the dentin. Fortify is a hydrophobic material. So what you need on root sensitivities is, one of several things. One that works real well is amalgam bond, a 4-meta material.
What?
Put the amalgam bond. Yeah, it works great, yeah.
Isn't that based on the glass ionomer?
No, amalgam bond is not glass ionomer, it's 4-meta.
Oh,
It's
yeah, okay.
polymethyl methacrylate with 4-meta monomer and trione-butylborine and HEMA.
No, I'm talking about the root sensitivities without the after periosurgery.
Okay, well after periosurgery, what you have is open tubules on the root. You have open tubules communicating with the pulp. All you have to do is put resin in the tubules. Well, getting it in there is a little hard to do sometimes.
What kind of resin? You need something that will close.
You need some kind of resin, yeah,
Sealant.
compatible. That's right. You need a resin that's compatible with collagen and Wetfield and dentin. And remember, dentin's 80% collagen. 4-meta is very compatible with collagen because the 10-3 etching agent they use, the ferric chloride, supports the collagen and lets the resin penetrate. That's why the 3's in there. The 10 is an etchant, but the 3's in there to support collagen. To keep the collagen from denatured. So now you penetrate 4 resin right through the collagen-supported matrix. And as soon as you get the 4-meta in the tubules, you have no more sensitivity. That's
So
one
which
way
one?
to do it. Several
Which
others
one
do.
is
Well, this is called amalgam bond.
Oh, so
Mhm.
Yeah, and advocate tenure for root
Yeah,
disease.
tenure works reasonably well because again, tenure will penetrate through collagen, decalcified with collagen.
Primary V.
Yeah, tenure works for desensitization. All bond works. The 4-meta products work. Another good technique is Gluma number 3, followed by one of the light cured materials. That works too. They all plug up the tubules. That's the important thing. Yeah.
Would you comment on restoring primary teeth?
Restoring primary teeth, huh? Well, yeah, I can comment on it, but the thing is, they're the same as regular teeth. You don't do anything different. It just is the pulps on primary teeth. You can abuse them a little more and they still heal because the patient attached to them is a little more, has more healing power. You know, kids will heal up faster than anybody else, right? But you treat the teeth the same way, right? I think we better shut off because we have another speaker he's supposed to have before 1:30 here.
Yeah,
I
well,
want to take all the time now.
you can ask one more question.
Oh, yeah, one more
Can
question
you
here.
give us the source for the caries detector, please?
Caries detector, Tin Man's a good source, or Danville Engineering, one of the two.
You have any numbers?
Well, the Tin Man I already gave. Danville Engineering, they have an 800 phone number. Probably right here. I don't know. I can look it up for you.
Where are they located?
Danville, California. Well, thank you. We can look that up here. Danville Engineering here. This is a good company. Wait a sec. Danville Engineering. Here it is. 800-827-7940. It's 827-7940. Danville Engineering. Direct sale.
Very much.
Okay, thank you very much.
Oh, you're welcome. Thank you. Thank you, Ed. Chance to come here and have a good time there. Hope I haven't shocked anybody too much now with all this wild stuff.
Well,
But
we've had some conflicting opinion, but I think it'll make everybody think a little bit
well,
about what they're doing.
well, you should bring in Charlie Cox now. If anybody in this room is using DiCal, bring in Charlie next year, and he'll give you 17 reasons not to use it.
The more complicated it gets, the better no dentistry appears.
Yeah, the best dentistry is no dentistry. That's right.
That's
Hey,
right.
that's good. Good idea. But then on the other hand, if you got pathology, I think we got to deal with that. The best thing is no pathology, right?
That's better.
Yeah, that's
Better,
better.
yeah.
Yeah, I agree. That's unanimous, huh?
Yeah, well,
Yeah.
we're gonna have a new profession, dental counselor.
Dental counselor to
That's
prevent all
right.
these troubles. I agree, Ed.
We're gonna have, Bill Moore wants to talk for just a couple of minutes. He's got some important information about a dental acupuncturist and what's going on with the acupuncture group here in California. Bill? Will you turn the lights back on here?
Those of you who are certified dental acupuncturists in California or who are grandfathered as dental acupuncturists in California, I want to talk to you a minute about a problem that's come up. Your scope of practice as dental acupuncturists is somewhat dependent on the scope of practice of acupuncture under the Acupuncture Act. There's a concerted effort being made right now to restrict that scope of practice and to eliminate from it some of the modalities that you commonly employ, such as EAV and similar things. And an effort is being made by the California Acupuncture Association to combat this. Now, heretofore, the California Acupuncture Association has been a little bit aloof and hasn't been too happy about dental acupuncturists, but I think they've come to the realization they need all the help they can get. Dennis, come up here just a minute. Dr. Tucker, who spoke here Monday, is with the California Acupuncture Association, and we're going to try to get the California Acupuncture Association to get in touch with all of the certified dental acupuncturists in California with a view towards creating a class of membership in the California Acupuncture Association for dental acupuncturists, because they need your support, they need your help. This does influence your scope of practice. When I defended Bonarada and got him off, I got him off primarily because of the Acupuncture Act and its scope of practice. We don't want to lose this, and you can lose it if you don't get together with the rest of the acupuncture. So, Dennis, you want to?
Yeah, well, I would just say a case in point. I spoke about lasers this morning, or during the symposium, and we had another speaker or two who were also speaking about lasers. Lasers are a cutting-edge technology, cold lasers, in both our fields, and there's an interface certainly between the two fields in respect to that. And currently, if we do not have lasers included within the scope of practice in acupuncture, it would be pretty hard to justify in respect to your scope of practice or standard of care the use of lasers. And so the problem is that there's a spillover effect. If we don't have the inclusion of EAV type devices in acupuncture and laser devices, then it is very likely then that dentists will not have anything other than their standard scope of practice to justify what they are doing. And so for that reason, it's also true for medical doctors. And so for that reason, there is a kind of linkage that perhaps many of us have not acknowledged before between our respective scopes of practice. And we hope that the solution to that will be passage of, well, legislation ultimately, but in the short term, certainly being able to get some decisive action on the scope of practice of acupuncture in this state that will clarify some of those problems.
There's one problem that you'll be aware of. Nobody in the CAA knows who the hell the dental acupuncturists are. Neither does anyone else. When they passed the Dental Acupuncture Act, they didn't require you to register. We need to find out a way that the CAA can find out who the hell are the dental acupuncturists in California. Will somebody help us? Andy, do you know who they are?
We can get the list from UCLA. It's the only institution that's doing the certification, and it's way down.
I mean, I know a lot of them personally, I know a lot of you guys, but there's a course that WK Chow has that graduates more every year. I don't believe anybody other than UCLA has any record of who the dental acupuncturists are. But if some of you gentlemen will...
The dental board has it because we have certification by the dental board at the end of the course.
2 years ago, they didn't have a record.
Oh, they don't care.
When we had Harada's case come up, that was one of their claims. They didn't have any way of knowing he was a dental acupuncturist because they didn't have a register of it. See, a lot of you guys are grandfathered. A lot of you guys were practicing acupuncture before the act was passed, and they don't have any way to know that. You don't have a professional association exclusively of dental acupuncturists. If some of you guys will get together with Dr. Tucker and see if we can't find a way to notify all of these people, and see if the CAA can't open up its membership and a special class of membership for dental acupuncturists, I think it would be a big benefit to both.
Are they opposed to our joining right now?
What was that?
What do you think, Megan? Yeah, I don't think we have to yes. Yes.
As an affiliate member, there should be no objection.
Yeah.
Look, the CAA is not the biggest organization in the world. It needs all the help it can get. It needs all the members it can get.
We were encouraged to join.
Yeah, and we think you should. We're encouraging dentists to join.
So do you have a phone number or anything?
I don't have that phone number with me. Do you have?
1-800-477-4564, I believe.
Okay.
Dial it. I'll repeat that. 1-800-477-4564.
Thanks, Megan.
Now, you're going to take some action to see whoever answers the telephone knows what these guys are talking about.
Yeah, I will be talking to people in the next.
I think it's very imperative for your own well-being that all of the certified dental acupuncturists immediately get in touch with the CAA and let's work out a cooperative program before you both lose your scope of practice, because it's an active program. The executive officer of the acupuncture board is working with your enemies to try to cut this down. We're going to do everything we can to stop it. We need all the help we can get, and I really would appreciate if you guys would call that number and let's find out who you are so we can get you in membership in that and get to work to preserve both of your scopes of practice. Thank you.
Thank you very much.